Hi guys, Dr. Gillard here. Let's do some dermatology, shall we? It is week 5. It is Wednesday. And yeah, let's do some dermatology. It's the spring of 2020. Let's talk about a precancer called actinic keratosis, also known as solar keratosis or senile. Why would it be called senile keratosis? It's because it's usually seen in older people who are senile. They're not all senile, of course, but that's just a word for older person or older persons. The actinic keratosis is the preferred name because AK can stand for other things, like gets confused with SK, seborrheic keratosis. You don't have to worry about that, though. For boards, they'll always spell out the name. There will be no abbreviations. So. But remember last week we talked about seborrheic keratosis, the great imitator. And I think we actually showed you a seborrheic keratotic lesion that actually looked like actinic keratosis. So there can be some mimicking of between these two as well. Actinic keratosis is a precursor of squamous cell carcinoma. It is one of the most frequently encountered skid lesions in dermatological practices. You guys will definitely run into that over your careers. And it occurs when some histological, when you do a biopsy, you can see that the keratinocytes are mutated. They're bigger than they're supposed to be. They have irregular shapes. They're hyperchromatin or hyperchromatic inside, and they're actually are classified as a low-grade dysplasia. So they are dysplastic. The key is that none of them are found in the dermis, at least not yet. They tend to live in the epidermis and hopefully stay there, but the trouble with these things is they can burrow into, once they get into the dermis, they have access to blood vessels and lymph vessels, and they can get into the blood and spread, and that's very, very dangerous. There are 3 categories. You can grade 1, 2, and 3. So grade 1 is the dysplastic cells are only found in the very bottom layer of the epidermis. Category 2 is they're confined to the bottom 2/3 of the epidermis. Category 3 is they're found throughout the entire, all 3 layers, 3/3 of the epidermis. And some people would say this is a squamous cell carcinoma in situ. These are all be taken off and evaluated, because sometimes you just can't tell this between squamous cell carcinoma can look really similar. One thing about grade 1, though, if it's only in that bottom layer of the epidermis, it can disappear. In fact, one of these can pop up maybe within 6 months to a year. It disappears. About 25% of the category 1s actually disappear. And let me get some water. Category 2 and 3 have a progressively less chance of disappearing. And yeah, the worse the higher the category, of course, the more likely it is to slip into full-blown cancer. Category 3 virtually never goes back. It's too much to go back. The full layer of the epidermis is evolved. There are some risk factors. All of these we're going to talk about. Sun is just evil. Years of exposure of your skin can cause these types of cancers. So cumulative exposure of UV radiation, UVA and B, sun exposure, tanning beds too. Tanning beds, you have UV radiation as well. So those aren't good. The lesions are found over sun-exposed regions, so that makes sense, right? Since one of the big factors of these things is old exposure to skin or old exposure to the sun, sunburn when you're littler. Which ones will become cancer? It's impossible to tell by appearance which ones will become squamous cell carcinoma. Not that's why it's better just to biopsy all of them, because you just can't tell. But there are a couple of really bad signs that it is cancer. One is it hurts. If it hurts, that means it's gotten down into the dermis, right where the nerves are. Another thing, if it's really thick, if it's hyperkeratotic, we'll look at a couple examples of those, tend to form on the ears. You can get this crust on the top and this yellowy crust. That's a bad sign. And if it starts oozing kind of some serum out of it, that means it's gotten down into the dermis. So nice question there, wouldn't it? The 3 choices. All of the following are risk factors for AK actually being squamous cell except blank. How does actinic keratosis present? Most of them have a yellow crust on the top of them. It might be a little toward the white side, but we'll look at a bunch of these. And underneath the crust, there is a background of erythema. So we have a red kind of red lesion, circular lesion, with a crust, a yellow crust on the top. Typically oval in shape. They can have scales on them, crusts on them. They can be macule when they first start out. They can be flat. They can become a plaque. They can become a patch. Lots of different presentations. There's several different types which have similar characteristics. There's a hypertrophic actinic keratosis, a pigmented actinic keratosis, a lichenoid actinic keratosis, kind of lichenified look to it, atopic. We're not going to talk about all these. We'll look at a couple of these. So here's what I mean. You can see it's blown up pretty high magnification. You can see the skin hairs here. So let's say that's probably 4 millimeters or so, getting close to maybe 6. 6 is the eraser, number 2 pencil eraser, 6. That breaks the ABC rule. I don't think it's quite that big, but you can see a bunch of them. You see the yellow flakes on a red background. That's never a good thing. That has to be taken off. Squamous cell can look just like that, honestly. So these need to be biopsied. Okay, they don't always present with a yellow. That's the trouble with these things. They don't always present. These are easy to identify, but sometimes they're a little bit more difficult. So here's a pigmented type of actinic keratosis where it doesn't. It just looks like it's pigmented. Still breaks the ABCs, way bigger than an eraser. Here's this one. Looks like she's got a little makeup on me. You can see this one is fainter. Nevertheless, AK. What are the chances of it turning into SCC, that squamous cell carcinoma? About 10% of these actinic keratotic lesions will morph into squamous cell carcinoma over a 10-year period. So it's not a tiny number, but it's not like 50%, but that's concerning. That's why they have to come off. Once the mutated keratinocytes kind of dig through the basal lamina, stratum basale, remember that's the bottom layer of the epidermis, they penetrate through that, they get into the epidermis, and now you got yourself a full-blown squamous cell carcinoma. The chances of it converting over a lifetime, not as many studies, but getting close to 20%. So they do like to turn, unlike the other one we're going to look at. That's cancer right there. That's not, you never should have a lesion like that. But here's a 7-year-old with actinic keratosis. You can see the crust here. That's all actinic keratosis. That's cancer. That's squamous cell. It could be basal cell as well. I don't know if we'll get to basal cell carcinoma or not. Basal cell doesn't metastasize, but it's very, very destructive. They could take a huge chunk out of your head to get the margins of that thing. Oh, yeah. Can you see the squamous cell carcinoma? Absolutely. Right there. Don't want to see nodular, especially things that look like they're bleeding like that. Juice coming out of them. Hypertrophic actinic keratosis. Same presentation, has the yellow, whitish scales on a red base, but the scales are crazy thick on these people. These always should be biopsied immediately because it's very difficult to tell this apart from a squamous cell carcinoma. Thick ones are not good. That means fast growing. And we can see it right here. Looks like just like a crust here, right? Like somebody dropped wax or whatever. That's hyperkeratotic actinic keratosis. No good. There's a forearm of somebody. You can see more white looking on this guy. We do know a little bit about gene mutations. There's a tumor protein P53, or the TP53 gene mutation, is strongly associated with this. UV radiation damages the basal cells in the stratum basale and mutates them, and they make mutated keratinocytes because of this. And this tumor protein P53 is actually a tumor suppressor, and its job is made in the stratum basale and basal cells. Its job is to patrol and look over the newly born keratinocytes and make sure they're not messed up, make sure their DNA is okay. And it also will stop, we won't get into all the details, but it also slows down their ability to replicate. Remember, cancer cells can replicate very fast, and it slows those down. There's a couple of examples. Anytime it looks bloody like that, that's not good. That needs to be biopsied. Right? This one's got that crust on it. But again, it's got that red. But it's not super red, but it's got that background underneath that. Remember, seborrheic keratosis can look really similar to this as well. That can be crusty looking. But seborrheic keratosis won't look like this. That's not a good thing. I mean, I wouldn't be surprised if that one came back as squamous cell carcinoma. Differential diagnosis. Well, as I said, seborrheic keratosis can look just like it. Even lentigo maligna sometimes can be difficult to tell. And then squamous cell carcinoma. I mean, actinic keratosis is a form of, it's a pre-squamous cell carcinoma. So sometimes it's really difficult to tell. How about this one? What do you think? Oh, that's kind of juicy looking underneath that with these big flakes. That can only be actinic keratosis, and you got to biopsy that. Again, I wouldn't be surprised if that turns out to be squamous cell carcinoma. There's that guy's head. He could see lesions all over. One there. Some risky occupations for many of these skin disorders, but anything where you're outdoors exposed to UV radiation, tennis players, golfers, mountain climbers, deep sea fishermen, captains of those fishing vessels, high risk for that stuff. Well, manage them. One way to manage them is stay out of the sun and use the strongest sunscreen that you can possibly find. It should have UVA and UVB in it. You can, once they are biopsied and they are determined to be maybe that stage 1 of actinic keratosis, you can use some retinoids, diclofenac gel, or topical retinoids to try to kind of soothe them or kind of take some of the color out of them. Won't probably get rid of them perfectly. Face peels, if they happen on the face, don't work that good, about 7%. If they're really widespread, laser surgery can help kind of calm them down a little bit so they're not so noticeable. These you can't, remember we talked about seborrheic keratosis, you can literally scrape it off with your fingernail. They use that curettage, that little sharp little hoop that they scrape them off. You cannot do that with these. Remember, these guys start down at the stratum basale, so it'll rip the stratum basale and it'll take some of the dermis, and you will bleed from these things. So you can't just use a curettage to take these off. Let's see if you learned anything. What's this one? Easy. That's an easy one, right? Nice and red here with yellow. So that's actinic keratosis. Another actinic keratotic lesion. There's a little yellow over here. This one, it wouldn't, got to be biopsied. Wouldn't be surprised if that turned out to be squamous cell carcinoma. Even basal, well, that doesn't really look like a basal cell carcinoma. How about this one? I see the yellow flakes in the red background. Yeah, this is all precancer. You could see it. It can be over quite a large area. How about that one? That's looking a little juicy, isn't it? That turned out to be squamous cell carcinoma. Got a little yellow in it. So that tells you it does not look like melanoma at all. And even seborrheic keratosis is not going to look that juicy looking. That thing is down deep in the dermis. How about this one? You can see the skin pores. That's probably a couple millimeters in size. It's variegated, but not very darkly variegated. That's just lentigo lesion there. Right? Old age spot. What about this one? It's got that waxy look to it. That is seborrheic keratosis. Remember that had the waxy look to it? How about that? Oh, that's easy again, right? Got the flakes on the top. You got the red background underneath that. That's actinic keratosis. That's pre-squamous cell carcinoma. How about that one? That's just an old age spot. It's lentigo. Lentiginous lesion. Old age spot. Senile freckle. I can't remember all the AKs. All right, now if you don't get it taken off and you ignore it, it could turn into squamous cell carcinoma. So let's talk about that. SCC or SC, I won't use any of those. I'll just be squamous cell carcinoma. Secondary to a mutated and rapidly growing keratinocyte. Has nothing to do with melanocytes here. We already talked about actinic keratosis. It's just actinic keratosis that has gotten in. These dysplastic cells have gotten into the basement membrane. Represents about 20% of all cases of skin cancer, so it's a good slice of the skin cancer pie. It is the second most common cancer. Basal cell carcinoma is the most common. Incidence is on the rise, possibly thinning ozone is one theory. The lifetime prevalence for a normal human is about 10% in white people. So this is definitely something you could run into in your older patients. There is an example of squamous cell. See, that doesn't look like actinic keratosis does. You can see the yellow flakes here, and you can see it's on a red background, but look how raised it is. Those are really fast-growing cells, and it's got like this weird kind of crust on it here. That's definitely not good looking, and that was squamous cell, or it is squamous cell carcinoma. And we know what it looks like already. Macule, rotted macule. They can have nodules like that one, right? Nice nodule right here. Ulcers, plaques. Yeah, they can have varying textures and colors. Can be almost impossible to tell them apart sometimes from actinic keratosis. Offered superimposed on an erythemic base, just like its precursor actinic keratosis was. How about this one? That turned out to be squamous cell carcinoma. You can see the crust, kind of a white-yellow crust. What you can't see is it's raised. The lesion does look like it's raised up. Turned out to be squamous cell. What are some risk factors? They're the same risk factors that we had for actinic keratosis. Sun. Here's another one. This could apply for actinic keratosis as well. The closer you live to the equator, the greater the chance you have of developing squamous cell carcinoma. In fact, there's some studies on this. For every 10 degrees of latitude, that you live closer to the equator, the risk of developing squamous cell carcinoma doubles for white people. Sun exposure, prior sunburns are huge risk factors. Even the use of tanning beds I didn't throw in here. I think they have that in basal cell carcinoma. Maybe we'll get to that one next week. So sun-exposed regions, again, we said that. 75% of these occur on the head or the ears or the neck where sun gets exposed. Sun-exposed regions here occurs secondary to prolonged cumulative UVB radiation, just like actinic keratosis. When they do show up in the face and in the neck, they tend to be more aggressive up here. I think we saw that one before. So that did turn out to be squamous cell carcinoma. Too juicy looking, right? Now these are older. The mean age is 72 when the diagnosis is made. The aggressiveness and the age are directly proportional. So the older you are, they tend to be more aggressive in older people. Your immune system's not as strong. Less aggressive if they show up in younger people. Males tend to be at greater risk than females. Unlike basal cell carcinoma, squamous cell carcinoma can metastasize. Basal cell carcinoma doesn't metastasize as much, but it's very destructive. Squamous can definitely metastasize. Not as dangerous as malignant melanoma, though. Malignant melanoma is just metastasizes just with a drop of a hat. That's why it's so dangerous. There are two risk groups that increase the chance of squamous cell carcinoma. Those who experience chronic UV radiation, sunbathers, of course, they're actually less likely to metastasize. The ones who have pre-existing skin injury from radiation or thermal injury or chronic ulceration, these people can develop very aggressive squamous cell carcinomas. It's also pretty rare, right, to have those. Some other risk factors: light-skinned, red hair always increases the risk for any type of skin cancer. Living close to the equator, we said. Having an outdoor occupation, just like sunbathing or likes to sunbathe, pretty much the same as for actinic keratosis. Blue eyes or red hair, hazel eyes increases the chance. Prior PUVA therapy uses Sorilin, which is a radiation, right? That's the treatment for other types of skin disorders, PUVA therapy. You drink Sorilin, and we won't get into all that, but human papillomavirus or genital warts increases your risk, not for getting skin cancer in your private parts, but getting it anywhere in your body in sun-exposed regions. So we don't know what the story is with that. Maybe the virus somehow lowers your immune system a little bit. We already said prior chemical radiation exposure. We said actinic keratosis is a very common precursor. In this study, 18% of actinic keratotic patients eventually became cancerous. A different study. Immunosuppressed patients, not good to be an AIDS patient and have some of these lesions. Anyone who's immunosuppressed, 65-fold increase. So that is not a good deal. Favorite targets, same thing for actinic keratosis: sun-exposed regions, lips, scalp, ears, hands, dorsum of the hands, face. Unlike basal cell carcinoma, squamous cell carcinoma really likes the scalp, especially people's hair is thinning a little bit. It likes inside the kind of a thinned head, kind of where it can hide. It likes the back of the hands, and it loves, we saw it on the pinna of the ear, the kind of the rim of the ear there. Let's take a look at some of these. This one on the dorsum of the hand. See the big nodule there? That really sets it apart from the actinic keratosis. Now that one looks just like actinic keratosis, right? You couldn't possibly tell that without getting a biopsy. So that one did turn out to be squamous cell carcinoma. That's the easy one, We got a red background. We really don't have much yellow anymore, but it's a raised, just ugly looking lesion. That just doesn't look good. So here's some yellowness around the eyes here, and then we got, just looks like actinic keratosis, but it biopsied as squamous cell carcinomas. See what you mean? See what I mean? You can't. Sometimes you just can't tell. Now we got lots of seborrheic keratotic lesions, but that is no good. That is cancer, squamous cell carcinoma. What do you do for it? Cryotherapy is the best choice for small ones. You can get them off pretty good. This is not like basal cell, so it doesn't dig way down into the subcutaneous layer. So you can get it out with that. Surgical removal for the big ones, though, is the gold standard. All right, let's talk about a precursor. We just talked about a precursor to squamous cell carcinoma. How about a precursor to one of the different types of malignant melanoma? And this is called Lentigo Maligna. So also known as melanoma in situ, a Hutchinson's freckle, Hutchinson's melanotic freckle, or AKAs. It's a precursor to malignant melanoma, but a special form called Lentigo Maligna Melanoma, or LMM. It's another way to say that. We'll talk about that in a minute too. Typically arises on a background of sun damage, just like all these do. It's considered a slow kind of horizontal growth phase of malignant melanoma, Lentigo malignant melanoma. But the good thing about this one is it's like a turtle. It usually takes years and years before it gets down into the dermis. So that's good. You may never even turn cancerous. It may stay in the epidermis the whole time. So that would be good. This thing is a mutation of melanocytes. It's got nothing to do with the keratinocytes. You remember your basic histology. These are keratinocytes made by basal cells. Basal cell would be right down here. Little stem cell-like thing making all these, giving rise by mitosis to all these guys. These are the keratinocytes, and as they go up, they differentiate. But these are mutations in the little octopi. And yep, they're not yet dysplastic in Lentigo Maligna. So that's good. Have not yet penetrated the dermis. Once it penetrates the dermis, you got yourself melanoma, and that is a very aggressive cancer that loves to get into the bloodstream, and it loves to get into the lymph system. This is probably, if you had to have a melanoma, this is probably the one to have because it's much slower moving than the other types. It could also, you see the word lentigo, we've studied lentigo, old age spots. So occasionally it can morph from lentigo without going through Lentigo Maligna. It can morph into a cancerous phase. Typically it goes lentigo, it morphs into Lentigo Maligna. Lentigo Maligna can morph right into Lentigo Maligna Melanoma, LMM. Predominantly, again, affects some sun-exposed areas, less commonly seen in other exposed areas. This is the type of, if you get malignant melanoma on your face, head, or neck, it's going to be Lentigo Malignant Melanoma, right? And it's going to start as Lentigo Maligna. 90% of the time, that's where these show up. They show up on the face and head and neck. About 10%, you can have Lentigo Maligna show up on your back or on your dorsum of your hand is another common place. But most of the time, it's going to be in a horrible spot for right on your face. Now, as I said, the prognosis is better for this one because it grows, the Lentigo Maligna grows like a turtle, and it can take years for this to manifest into cancer. and maybe it never will. Diagnosis, if you're diagnosed at the age of 45, there's some studies done on this. We follow them to age 75. About 3% of them actually it morphed into a cancer. That's not too bad. The lifetime risk is not as bad as squamous cell carcinoma. 5% is the lifetime risk for this. And here's the classic. I thought I blocked this out, but it looks like it's here. But there's the initial phase, Lentigo Maligna. Might even think it's just a lentigo lesion. But you can see it grows, but it grows inside the epidermis. It grows outward. It's a radial growth phase, meaning it grows radial, like this kind of the spokes of a wheel, outwards instead of down. So it can do that for many, many years. But then all of a sudden, instead of growing outward radially, it grows straight down and it penetrates into the dermis. And once it does that, you got yourself melanoma, specifically Lentigo Maligna Melanoma. All right, Lentigo Maligna Melanoma. So these usually show up around the age of 65. Several sources have said that. Bolognia said that as well. 90% of the lesions occur on the face, as we said, 10% in other exposed areas. Same data for Lentigo Maligna. They're typically fairly large, 5 centimeters, like 50 millimeters, huge. They're called Hutchinson's freckle. And it could take usually a decade before it becomes cancer, 13 years on average. And yep, about 10% of all melanomas are this type, Lentigo Malignant Melanoma. What does that mean? What's the first thing when you read this? What's the first thing you think? Melanoma on the face. Melanoma on the neck or the head or somewhere. On the face more than anything else. What are the risk factors? Sun exposure. I mean, Dad didn't even put that, but you can, it's down there, who likes the sun. Sun exposure. But there's a gene mutation on chromosome 10 that they've discovered. I don't think that'll show up on board, so we'll stay away from that one. Females who've taken progesterone therapy and estrogen replacement therapy for menopause are at slightly increased risk for the development of this type of cancer later on. This is the red hair dye one. There was a little controversy. Those studies weren't the greatest, so there are a few studies that show specific type of red hair dye increases the risk of this cancer later on. What's the difference between Lentigo Maligna and Lentigo Maligna Melanoma? Well, Lentigo Maligna Melanoma is a full-blown cancer. Dysplastic cells can take off into the blood, very dangerous. The Lentigo Maligna, it can be variegated, but it's usually not raised, and that's the best way to tell these apart. Lentigo Malignant Melanoma, it has nodules, right? And they can be black, they can be brown, they can be blue. Lentigo Maligna will not have nodules, and the variegation will be more lightly variegated. It'll be a light brown, maybe a really light black color, but not so with cancer. It'll be coarsely variegated, dark black, super light brown. We'll see a bunch of pictures right now. So what do you think of this one? It certainly has been growing for a long time, but see how it's been spreading out. And it's really hard to treat, right? How are you going to treat that? You can't do surgery. You can't take off her whole forehead. So you just monitor it. And this is Lentigo Maligna. There's no cancerous nodules here yet. Now this is melanoma, Lentigo Maligna Melanoma. So we have a nodule right here, but it's very densely variegated. It's super dark here, almost black, dark brown. It's super light over here, way bigger than a pencil, number 2 pencil eraser, way bigger than 6 millimeters. Can't fold it in half. Yeah, this is all cancer right here. This is still probably non-cancer, what's a little bit less, but yeah, this has got to come off. And if she says, no, I don't want to live, I don't want to have a huge scar on my face. And they do reconstruction. If you ever watched the Pimple Popper, how she does reconstruction with this, you can put skin back and try to rebuild it. It's not like they're going to leave a hole in your face. How about this one? That's Lentigo Maligna. It's too big for Lentigo. So it's Lentigo Melanoma or Lentigo Maligna. So it's the precancer phase. There's no huge nodules in it. How about that one? Lentigo Maligna. Oh, man. You guys better not miss that one, right? Got a huge... Why the guy waited this long to come to the dermatologist? There's a huge nodule right here. That's all cancer. That's probably down in the... under the subcutaneous. Probably getting into the bone. That's not good looking, though. What's the treatment? Well, you got to take out the lesion. Surgical removal, real wide margins. It's going to leave a pretty good scar there. They can try to fix it, though, with plastic surgery. But it's not going to look the greatest. The second best treatment, a lot of patients just choose, they're older, and they say, I don't want my face looking. Oh, man, excuse me, slate. Sorry, I'm not going to be able to edit that out. That's going to make you guys sleepy. What is it's like 11 o'clock. Let's see. So oftentimes the lesion is just too large. So the next best treatment is superficial radiation therapy. And it's got pretty good success, about a 93% success rate for getting rid of the cancer. So it's a pretty good treatment option. Look at that. That's definitely, that's just nasty. That's Lentigo Maligna Melanoma. You don't get melanoma on your face because there's other types of melanoma. If it's on your face, it's Lentigo Maligna Melanoma. So this looks like a guy, I would say, chose to, no, I think it's a lady. But they chose to do radiation therapy. It would leave too big of a lesion here. And it cleaned it up pretty good, I have to say.